Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Welcome to Expert Perspectives. This is your host, Tom Urochi, and today's topic is mantle cell lymphoma, which of course is a rare B-cell lymphoma. And we're delighted to be joined by our guests today, all of whom have expertise in this area and are recognized for their contributions to the field. So without further ado, let's take a moment for introductions. Dr. Jain, would you like to begin?
Yeah, my name is Pritesh Jain. I'm an assistant professor in Department of Lymphoma at MD Anderson Cancer Center.
Great, thank you. And Dr. Shah?
Hi, I'm Bijal Shah. I'm a senior member at the Moffitt Cancer Center in Tampa, Florida.
Wonderful. And last but not least, Dr. Wang.
I'm Michael Wang. I'm a Pudding Clark Endowed Professor in the Department of Lymphoma Myeloma at MD Anderson.
Wonderful. Well, thanks to each of you for being a part of this, and it's an honor. So let's dive in. So the topic here, or theme, is frontiers in mantle cell lymphoma and integrating immunotherapy and responding to resistance.
I really think that after CAR T cells, there should be some maintenance. But right now we are not able to do it. Why? Because after CAR T cell, there's the B cell aplasia, and the Y cell also low, and the immunoglobulin also low. And I think the maintenance we haven't found it. Maybe in the future we will be able to find something to make the CAR T cell persistence longer. Maybe we will be able to find agents that diminish the upregulated negative microenvironment agents like anti-TIGIT antibody, get rid of the Tregs, get rid of the bad environment. Maybe a good maintenance therapy.
Yeah, I know you bring up a great point. Can we wake up a sleeping car? Right. I say that at meetings, where I present often. The problem for me isn't persistence. The problem for me is activity. We never, even when we see persistence, Michael, right? When we see hypogammaglobulinemia and B-cell aplasia and you name it, we never see the CAR grow. We have tracked it by every measure imaginable, digital droplet PCR, you name it. We achieve some steady baseline in some patients, or it completely goes away to where we can't measure it. But nothing we have done has gotten the CAR T cell to grow again, including recurrence of the mantle cell lymphoma. And I find that really, it's a tough nut to crack. So I agree, TIGIT, or who knows, whatever the immunotherapeutic strategy may ultimately be, if we can find some way to keep those CARs
we basically need our own checkpoint inhibitor. Mm-hmm. Okay. So we find PD-1, CTLA for the solid tumors, lung cancers, renal cancer, breast cancer, colon cancer, you name it. They all benefit of the PD-1, the checkpoint, and even that is good for the Hodgkin's lymphoma. But when you use that to large cell lymphoma, response to 9%. Okay, and mantle cell lymphoma is an immunocold tumor, and it doesn't work. But when you stir up this microenvironment with the bispecific antibodies, CAR T cells, maybe on the personalized precision basis in the future, we will find out something in the microenvironment, either a checkpoint inhibitor or something else that we can intervene and make the patient immunity sustain. And stay away from infection and keep the tumor away for a longer time.
Yeah, no, I mean, Michael, that's one of the reasons why we were excited to be a part of that Lin-Acala monoclonal trial that you mentioned, right? Because the hope is we use this to stimulate immunity, and if they progress, we've got CAR T on an immune hot environment. We're going to delve into the frontiers. I think it's important to stress that the TIGIT data actually came out of some single cell sequencing data done in the post-CAR setting by Michael, you and your laboratory group. And so it didn't come out of nowhere. It was, so targeting that particular co-inhibitory ligand was again based on some elegant single cell sequencing work that got us here. Pritesh, you're the expert on BTK resistance, so I'll turn to you. What do you think about BTK resistance? What drives it, and what do we do about it?
Yes, sir. So there are like several unanswered questions in that area, because we know that BTK is such a large protein. There are several domains, protein interaction domains, which are present, SH2, SH3, and also the kinase domain. So the way in which it is working in mantle cell is, I think, there are several other elements which are the co-activator molecules, which are chaperone proteins, and those proteins are in turn influencing the kinase. For example, one of them which was reported was HCK. So that HCK kinase is very important and plays an important role upstream of the kinase domain. And I think addressing that as a scaffolding protein targeting agent would be a much better strategy in MCL, because we know that there are other microenvironmental influences there. So I think those are the things which are playing a role in the BTK resistance there. And also, of course, the way of clonal evolution and how the different mutations are evolving at different protein interaction domains. And I think that is what is another important aspect.
Okay, so the natural history of mantle cell lymphoma, it is a response, relapse, response, relapse. And because the efficacy initially you treat, the resistance is almost zero. When you treat and then you have, let's say, 100% response, 90% response. The second time you treat it, because of a build-up of resistance, you have 85% response, and the period is getting shorter. And then next time is 60, 45, 50, and until the end, when the resistance becomes 100, the patient response is zero. So this is a natural process. No matter whether you use BTK, chemo, or transplant, CAR T cell therapy, even bispecific antibody, the same thing, right? Is the more you treat it, the more resistant it is. Is this because of the BTK? Not totally. This is mainly due to the progression, the natural course plus BTK, because after BTK, we don't have good therapies until we find the CAR T cells. So the CAR T cell totally reversed the BTK resistance, okay? But now we're dealing with the CAR T cell resistance. Then we have antibody resistance. So the more you treat, the more success you have, the more aggressive, the more resistant the tumor is. The current combination need more than one partner. So yeah. we find that ibrutinib, the BTK inhibitors really synergize with the BCL2 inhibitor. We also think that nothing can beat the old rituximab. You cannot do any combination without rituximab, right? So the three is become the backbone right now, right? But we wish to maybe to add some bispecific antibodies, and we may wish to induction for the CAR T, but this three compound is the current backbone, and I'm sure in the future, like myeloma, in the future we are going to have quadrants, and then maybe occasionally 5 for the ultra high risk. And we don't have to do the compound together. We can do 3 in a row, and we can use CAR T cell or bispecific body consolidation. Then we use a different antibody on a different CAR for maintenance. We are going to be is blossoming B-cell lymphoma. It's blossoming.
Michael kind of did a phenomenal job kind of speaking to this idea of sort of the acquired resistance over time. De novo resistance at baseline, and then acquired resistance over time. We as we think about leveraging targeted therapy, our dance partners, right? How we combine them is probably going to be driven by the patient, their comorbidities, probably driven by the lymphoma. How aggressive is it? How hard do we have to push? And then, as we develop molecular, data, we don't always have it on day one, but, within a couple of weeks, how we adapt to some of the molecular findings to also tweak what we're doing, or at least provide some expectation of how we need to consolidate, how soon we need to consolidate, But it really, that's why you have the three of us here talking, right? I mean, it's having that understanding of when do I really have to push hard and how hard do I have to push, that just comes from seeing a lot of mantle cell lymphoma and seeing these patients come through the door, right? It really isn't a one size fits all. It can't be. And we're always going to be battling until we find a way to cure this disease. Always going to be battling resistance or sort of think of it as one resistant cell that always gets left behind. But as that resistant cell grows, right, that's what we have to treat the next time it relapses. BTKs are extraordinarily powerful, right? But those large sticky cells that stick around in the microenvironment in the presence of a BTK inhibitor, I don't know if there's an easy way to fix that. Maybe BTK degraders, as Dr. Jane was mentioning, targeting the BTK scaffold will help us liberate some of those ugly cells and starve them of their, of that, home that which they live in. But we've still got so much learning to do in that regards. I'm very excited about bispecifics. I'm still learning how to integrate them into clinical practice. They're not FDA approved. And so it's a lot of, pushing for appeals and compassionate use exemptions and the like to try and get them into patients.
Well, thank you. Thanks so much for each of you for joining today. And I just wanted to say it's been a pleasure. And I think our audience can tell that there's a lot going on right now in terms of things that might improve outcomes in the future. So for more on this topic and many others organized by disease state, please visit our website on expertperspectives.com. Really appreciate everyone's time, and thank you so much. Take care.
Thank you so much.